On behalf of the Children's Oncology Group, I wanted to thank Lenny and the organizers of the conference to give us the opportunity to come and speak today. In the 10 minutes that I'm allotted, I wanted to just give a brief update of some of the recently closed, current, and soon-to-open COG trials. I have no disclosures, and I also need to ask for your permissiveness in the fact that I lost my slides for this talk are somewhere in the Newark International Airport. So I sort of had to scramble, so just bear with me and please be patient. Basically, a couple areas that we wanted to cover today is just quickly go over classification, risk stratification in COG. I wanted to talk about some ongoing trials for B-ALL, then T-ALL, and then I wanted to just close with some data on AYA enrollment on COG-ALL trials over time. So this risk stratification and classification schema is really the heart and soul of COG trials. We have patients who are diagnosed locally at their institution, and then they are enrolled on a classification study. The current study is 08B1. It's chaired by Dr. Patrick Zweiler-McKay. And as you can see at the bottom here, we have a number of laboratory specimens are sent off for immunophenotyping, DNA index, genomic studies, cell banking, which is very important, obviously, MRD day 8, peripheral blood, MRD day 29, and then a number of molecular markers that we've talked about through the course of this conference. With this data and the measurement of MRD at the end of induction, we're able to classify patients into various risk groups, as shown here. For BLL, we have low risk, average risk, high risk, very high risk, and Philadelphia chromosome positive. For T-cell leukemia, we have standard risk, intermediate risk, and very high risk. So I'll start off just with a few comments on B-ALL. This is our most recent completed B-ALL trial for high-risk disease in COG. This was the 0232 study that we've talked about earlier this morning. In bullets 2 and 3, I show the AYA population, and we were fortunate that overall 20% of our enrollees were in the 16 to 30 age group. As Steve Hunger mentioned yesterday, and I know Archie Blyer talked to, this next group, greater than 21, was really quite a fall-off, and we really only had a small group of patients, but there were 47 patients for overall 1.5% of the total patient enrollment. The study itself was a modified, augmented BFM backbone with 2 questions, as Steve mentioned this morning. We have dexamethasone versus prednisone during induction, and high-dose methotrexate versus Capezi methotrexate during interim maintenance 1. The results of this trial were that for younger age patients, that is patients less than 10, dexamethasone-containing regimens were superior to prednisone-containing regimens. And for all patients, high-dose methotrexate was superior to Capezi methotrexate. The successor study that's chaired by Michael Burke, who's here at the conference along with Wanda Salzer, is sort of the next step, and patients are divided. Previously, patients who are high risk are now split off into high risk and very high risk based on clinical characteristics, response to therapy, and obviously their molecular phenotype. High-risk patients are treated on an augmented BFM backbone, and they are randomized to receive either intrathecal methotrexate or triple intrathecals throughout the duration of their therapy. The very high-risk patients, there was a 3-way randomization between sort of a standard augmented BFM backbone and 2 experimental arms. Experimental arm number 1 was the inclusion of cyclophosphamide and etoposide during consolidation in DI. And experimental arm number 2 was the same inclusion of cyclophosphamide and etoposide, but also with the addition of clofarabine. This trial opened in 2012. As of last month, it's over 2,000 patients enrolled on study. The study has been going smoothly with one exception, and that is with experimental arm number 2, that's the clofarabine. Excess toxicity, particularly infections and delayed long periods of myelosuppression, delaying the next phase of therapy. The trial was halted. There were revisions made. The clofarabine dose was decreased from 30 milligrams per meter squared to 20 milligrams per meter squared. The trial was reopened, and unfortunately, again, we saw the same problems in terms of increased infectious toxicities, including grade 4 and 1 grade 5 infectious toxicity, as well as very prolonged periods of myelosuppression up to 80, 90 days after the start of a course. So unfortunately, the schema kind of looks like this now. The clofarabine experimental arm number 2 has been permanently closed. Going forward, Mike and his colleagues are working on reopening the very high-risk stratum as a 2-arm study just between the experimental arm 1 and the standard. And as has been mentioned by a number of speakers, we're trying to carve out the patients who have a pH-like signature, and we're in the process of doing that, and to incorporate targeted therapy on backbone therapy. I wanted to just briefly mention a couple other trials that are in the horizon. Pat Brown at Hopkins has been working diligently over the last few years to open up a comprehensive B-ALL relapse. Historically, in COG, we had several smaller studies that were targeted for certain types of relapse, and the beauty of this protocol is going to take sort of all comers with B-ALL relapse. We hope it's going to open in just a couple months. The risk stratification will be based on time to recurrence, what type of relapse, marrow versus extramedullary disease, and then the most important probably is response to reinduction therapy. The study design itself will be a randomization on an R3 backbone to receive or not receive blinatumomab, and there'll be options for high-risk patients to come off study and go to stem cell transplant. Louis Silverman at Dana-Farber Cancer Institute, along with Steve Hunger, have been working diligently with our international colleagues to get a pH-positive ALL study up and running. One of the key features is the early and continuous use of a TKI. In this case, it would be the traditional imatinib. Patients will be risk stratified based on MRD response. Good responders will be randomized to receive COG-BFM therapy versus SFOL chemotherapy, the international regimen, and high-risk patients will receive SFOL chemotherapy followed by stem cell transplant. Briefly, T-cell disease. The recently closed 0434 that Steve mentioned earlier, that was chaired by Stuart Winter and Kim Dunsmore, had a total of 1,836 patients. And if you look at the AYA population, the group between 16 and 30 was a little bit lower than in 0232, but still a reasonable population of a 15%. And interestingly, that small group over 21, they actually had a little bit higher success. That may just be due to the epidemiology of the disease. The experimental design was a modified BFM backbone plus minus nelarabine and high-dose methotrexate versus Capizzi. The study literally just closed, and obviously it's too early to report any results. David Chichi at CHOP is organizing the successor T-cell study, and this will be for patients with T-ALL, but also for patients with T lymphoblastic lymphoma. It's a modified augmented BFM backbone, and it's studying the inclusion of bortezomib or not in a randomized fashion. And then finally, I just wanted to show this slide that Minnie and Steve forwarded to me last week. And basically, this just looks at the age distribution of patients who are enrolled on COG-ALL trials over 2 time periods, 2000 to 2005, and then 2006 to 2009. And obviously, our big group here is between 1 and 9.99 years. That's the overwhelming majority of patients. But if you go down to the last couple lines, we're seeing over those 2 time periods an increase not only in the enrollment of patients between the ages of 16 and 21, but also 22 years and older. These trials accept patients up to the age of 30. These are small numbers, but I think if you're optimistic like I am, we think that these trends will continue. So thank you.